Hello, I'm Miguel Reguero on behalf of CME Outfitters. I would like to welcome and thank you for joining us for episode 2 of a 3-part CME Outfitters cast series on best practices in the treatment of underserved populations with IBD. Today's episode is titled The Role of Socioeconomic Factors in Healthcare and Delivery in IBD. This is supported by educational grants from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, and also Takeda Pharmaceuticals USA Incorporated. This activity is brought to you by the CME Outfitters, which is an award-winning accredited provider of continuing education for clinicians worldwide. As you know, I'm Miguel Reguero. I'm chair of Department of Gastroenterology, Hepatology, and Nutrition in the Pierre C. and Renee A. Bora Family Endowed Chair in Gastroenterology and Hepatology. I'm also the vice chair of Digestive Disease and Surgery Institute and professor at the Department of Medicine at Cleveland Clinic Lerner College of Medicine, Case Western Reserve University in Cleveland, Ohio. And it's my absolute pleasure to welcome and have Dr. Quezada join me. Dr. Quezada is not only a good friend and colleague, she's an exceptional physician who's really pushing the envelope in terms of education and healthcare disparities. Dr. Quezada is an associate professor of medicine in the Division of Gastroenterology and Hepatology, associate dean for admissions, and assistant dean for faculty diversity and inclusion at the University of Maryland School of Medicine in Baltimore. Welcome, Sandra.
Hello, Miguel. Thank you so much. It's great to see you. Happy New Year.
Great, and Happy New Year to you, and I look forward to this program. So, Sandra, to frame today's episode, let's start by reviewing our learning objective, which is to really initiate multidisciplinary collaboration between medically underserved children, adolescents, adults with inflammatory bowel disease with guideline recommended care. And if I can, let's start with this components of socioeconomic status. Let me have you take us through this, and along the way, I'll interact with you and have some dialogue because I think this is a great presentation that you have.
Absolutely. Thank you, Miguel. And thank you for including this as part of the discussion because, we talk a lot about socioeconomic status and we kind of throw the term around a lot, but I don't think we often pause to really concretely consider what are the factors that we're really talking about when we say socioeconomic status. So historically, we usually define socioeconomic status as being impacted by one's employment status, income level, education, and you could think of those as sort of patient, directly patient-related factors, but there are also environmental factors that our patients are encountering on a day-to-day basis that absolutely influence their socioeconomic status. And you think of it as, again, it's their positioning or standing in society. And when you think about it also in terms of how this influences their health outcomes, what we're really talking about are social determinants of health. And so in addition, some other environmental factors you might want to think about could be housing situation or one's citizenship or immigration status. I mean, just think about the access, privileges, opportunities, or lack thereof that one may have depending on, say, their immigration status, both for education, employment, housing, and health insurance for that matter. And the other thing that I think is important to highlight, especially in this last year, we've recognized racism as a social determinant of health. In fact, the AAMC has coined this as a public health crisis. And so I think that's another important factor that we should be considering. And then finally, health literacy is something I think we don't talk about enough in medicine. Historically, again, we've always thought about it as more on the patient side and thinking about how a patient or an individual is able to access and understand information. But in the Healthy People 2030 now, the newer definitions, they've really broadened it more. So it includes not only how they access and understand the information, but also how do they utilize it. And then also it puts us, the providers, the organizations, in the equation as well. So what is the health literacy of the organization, institution, of our clinic, for example? So how well do we provide that information? How well do we enable our patients to understand it? How are we supporting them and facilitating their ability to utilize that information? So again, really going beyond just thinking the direct patient-related factors, but also now thinking about societal, environmental, and the health system-related factors.
Yeah, and I really like how you came up with these 4 domains on socioeconomic status and impact. And I think really the pandemic in a way has brought to light so many of the disparities that exist in general, I should say. But then it's interesting as we move into socioeconomic factors, and I know you're going to discuss here in a minute the outcomes in IBD. Tell us a little bit about socioeconomic status in IBD care, how socioeconomic status impacts on care and outcomes. Maybe walk us through that a little bit.
I think that there's a couple different things that are important to think about. Again, when we talk about socioeconomic status, and if we're thinking about some of those environmental factors in the US, we know that, healthcare insurance is not universal, and not everyone is going to have the same access to some of highly powerful IBD therapies that they might need to access, or even if they have some coverage, sometimes transportation to get to an infusion center, for example, it can be a huge barrier for some of our patients, depending on what their neighborhood, again, and housing situation may be. So these are, I think, important things that all of us in IBD care should always be cognizant and thinking about. And this particular study, I think socioeconomic status has probably been studied most extensively in some other chronic disease processes like diabetes and hypertension, but it's certainly been looked at in IBD as well. And I thought this was an interesting study, not only because it was recent, but it's a large study. It was conducted in Canada, where there is a universal health system. And even with that, what you would think of as a general equalizer, there still were disparities in outcomes for IBD patients. And so, with these over 9,000 patients with IBD that were matched to IBD controls for age, sex, and for their neighborhood, what they found was if they had any of these indicators of lower socioeconomic status that had to do with employment, income, education level, so with single parent household, that was also included. You didn't need all 4 of those things. Any one of those things resulted in an increased risk of having IBD-related hospitalizations, all-cause ICU admissions, high-dose steroid use, and all-cause mortality. So again, I think it sort of stresses and highlights that even with relatively equal access, you could say, through health insurance in a universal system, some of those patients that have more resources and more means would supplement that with additional private insurance in order to get even better access and care regardless. And it also, again, recognizes the notion that we have a tendency to risk stratify our patients through more sort of biological factors, and we think about their age at diagnosis and their family history, which are very important as well. But maybe we need to start factoring in some more of these social factors, since we can see that these really do also pose a greater risk for complicated disease courses in our patients.
Yeah, and I think it's interesting as I heard you talk on this and thinking about medical homes, population health, we see sometimes that you mentioned healthcare literacy, education in general, socioeconomic influences on utilization. So unplanned care, ER visits, hospitalization. And I thought it was interesting in the Canadian study that you mentioned, higher use of medicines in general, except biologics. So there is some disparity in terms of biologic use in this group of patients. I think that we kind of flipped to this slide here on influence of social support. Maybe walk us through, I've heard you talk about this in different conferences, and I know you're very passionate about how do we improve or look at social support in general for IBD patients and management?
Again, I think it starts with having those conversations with our patients and developing our own awareness of where our patients are in that moment with respect to their socioeconomic status. What is their current employment status and income status, and recognizing that those things are not in fact static, but they're quite dynamic and they can change over time. And, in IBD, we have that opportunity. We're positioned to have long-term relationships with our patients, and that we can monitor that over time and not only recognize what it may have been, at their first visit, but to recognize the stability of that income or of that employment status, for example, and then using that information, not just for our own, knowledge and understanding, but how are we going to act on that? I think those of us, I know that in your practice, also at Maryland, we're fortunate to have a social worker involved as part of our care team so that we can have access and have some case management there to provide that as additional assistance. And not everyone has that, I think, but I think at least having that awareness, asking those questions, offering some resources and support to our patients so that they can try to navigate this very complex system.
Yeah, and I think we're seeing actually better outcomes now when we do that. And you're right, not every practice and not every community has that support. Maybe let's shift gears. We talked about socioeconomics and talking about gender disparities and unconscious bias. Kind of talk us through this. Obviously, this is also an area that you've spent time not only personally researching and talking on, but how does this impact IBD? And give us some of your thoughts on gender disparities.
Absolutely. So I have a really strong interest in unconscious bias with respect to multiple different dimensions. But, I think with respect to gender, it's interesting. I think there's been a lot of information and literature that look at gender differences in IBD. And certainly a lot of them, again, are patient-related, I would argue, factors. We know that with respect to age, there may be some greater prevalence of Crohn's versus colitis. The younger patients, we seem to see more ulcerative colitis in male patients. And then as they get older, we might see more Crohn's in female patients. Although one thing that's interesting, again, to think about that overlap is smoking history and how that overlaps. It seems that in the general population, women are more likely to be smokers. And so that could also maybe be influencing and modifying the disease prevalence of UC in that patient population. But another thing that I think is important to think about is, again, the physician side. We do spend a lot of time studying patients and the patient-related side, but there's two sides to this equation. And we know that the physician-patient relationship is so important, especially, I think, in IBD. And so there have been studies that show that physician-patient concordance, for example, in language or in race, do show that there seem to be greater patient satisfaction. Actually, they feel that they better understand what the treatment plans are. They're more open to following up and just have a general sense that they had a higher quality of care when there is both race and gender concordance. But again, what about the physicians? And so we're humans too, and we all have our own implicit biases. And so we need to do, I think, a better job of developing self-awareness and really studying and learning about physician behavior and patterns and recognizing how our biases may influence our treatment decisions and ultimately our outcomes for our patients. An important overlap for this would be, I would argue, mental health, for example. And so we know that mental health is tends to be more prominent in general population in women compared to men. And historically, if you think about 100 years ago, women would get committed to a mental institution for just not behaving to their husband's preferences, for example. Fortunately, we're beyond that now. But interestingly, in some of the more recent studies, actually, they show that hospitalization rates for mental health are comparable between men and women, but that the women are more likely to be victims of physical and sexual trauma. And so I think that that's a really important thing to keep in our minds as we are and meeting patients and encountering patients that have that dual diagnosis of IBD and mental health issues. We should be asking about trauma history to make sure that we're aware of that. We're not missing that very important piece of their history, but then also recognizing that there is sort of this narrative with that association of women and mental health. And unfortunately, what that they can sometimes lead to is a disbelieving of women or a delay in their diagnosis. And sometimes we're more likely to attribute symptoms that women report as being sort of more psychosomatic or maybe less likely to be what we call sort of organic disease processes. And so the danger there again is that we could be delaying important and very necessary therapy for our women patients. And we know that that's actually true in other disease processes, in particular with maternal mortality in Black women. So now we're talking about intersectionality, and you're including gender and race, that there is, again, a problem with implicit bias there that's clearly, unfortunately, playing out in a basically in the worst way possible for our patients. So again, I think the theme here is that we really need to develop our self-awareness and have an understanding of what our biases are with respect to gender, with respect to race and socioeconomic status, and ask ourselves these questions as much as we are trying to ask questions and learn more about our patients.
Yeah, these are such critical points you mentioned. And I think it's interesting that, at least from perspective of patient-centered care, as we move into COVID here, is including the patient's voice in a lot of this, because we learn from the patient stakeholders. So let's switch gears now. Obviously, there probably isn't an hour, a minute, a day that goes by that we don't talk about COVID. But let's spend a couple brief talking points or slides on COVID, and then I'll give you some wrap-up time. But tell us about COVID, how it's impacted your practice, and kind of what you're seeing also in terms of disparities with COVID, as you've alluded to already.
Absolutely. Well, I mean, I think that one thing that was important for me to do, especially in the beginning, in the springtime, was to just remember that all of the risk factors and reasons that any individual might have a higher risk for contracting COVID or for having more severe outcomes for COVID are just as true for my IBD patients as they are for the general population. So if they're older patients, we know that in race, actually Hispanic patients are more likely to be infected with COVID-19. It looks like they're also more likely to be hospitalized, as are our Black and Native American patients. We know that Black patients, at least as of, I would say, data from August or so, it was definitely reporting increased mortality for Black patients with COVID. So clearly more severe disease outcomes for these communities. But then fortunately, at least thanks to the secure registry, what I was able to see was that it looks like having IBD alone isn't necessarily increasing my patient's risk for either contracting the illness or developing higher risk or worse outcomes. I've certainly, in terms of how it's impacted my practice, I would say it's just been increased communication with my patients. My patients have had tons of questions, understandably. Should I stay on my therapy? Is this like the worst time in the century to be immune suppressed? And now with the vaccine coming out, a lot of questions about whether or not they should get the vaccine. I had a very earnest conversation with one of my Black patients who just flat out told me he has no plans to take the vaccine, understandably is hesitant and has a lot of mistrust for the healthcare system. If anything, it made me feel a little, I felt honored that he actually trusted me to give him his biologic therapy that he's getting. And I do remember that we had a very intense conversation about that years ago. But we decided, we kind of left it as an open conversation. It was not something we were able to settle in the one visit. And I think it's going to require ongoing, readdressing, seeing where we are as more people get vaccinated. I hope that more of our IBD patients feel more comfortable with taking the vaccine, because I think we all agree that the risk of the vaccine is far outweighed by the risk of COVID.
Yeah, no, and I think the disparities we're seeing in terms of now with the vaccine at the time of this recording just being out for a month, and still not widely used, is this distrust, this concern. And then I think the secure IBD registry, I think comforting to me is that we didn't see any changes in terms of IBD. The biologic therapies appear to be safe in the time of COVID. And then to your point, the vaccinations, we are recommending those for our patients, but we're going to continue to track that. So Sandra, that's great. Let's now kind of move to the final part on what are some resources that you would see for your underserved patients? What are out there? What do you guide or what do you recommend? Maybe talk through a few of the resources available.
Absolutely. Well, I think, I'm probably sort of partial. I find that the Crohn's and Colitis Foundation often has a lot of really wonderful resources for our patients. So I'm frequently reminding my patients and letting my patients know about the foundation, about some of the different financial assistance programs, and definitely support groups. I think, again, as we talk about a patient's sort of position in society, probably another really negatively predicting outcome or social determinant of health is feeling isolated and feeling alone. And I think that finding these support groups certainly is a way to give our patients a sense of community and learn from peers that have been through similar experiences. So I think those are really important supports for our patients. Again, we're fortunate that we have a social worker in our practice who can also help with some of the different financial programs that might be out there. But again, getting back to the support group, I also wanted to suggest that the ostomy.org is another great site that patients can use to find multiple different kinds of support groups, but specifically for those who are postoperative patients. I think that that's a unique, clearly a unique community and have different conversations and needs. And so I wanted to mention that. And finally, another unique community, I think in many ways are minority patients. And so here's another, The Color of Crohn's and Chronic Illness is another great resource for those patients.
Yeah, and also to remember for everybody, the CME Outfitters does have a gastroenterology patient hub, and you can find additional resources there. Sandra, so as we move to the SMART goals, I want to thank you. I always learn from you and enjoy listening to your perspective. And healthcare disparities, I think the gender inequities, the gender disparities really is kind of eye-opening. I think COVID has brought out some of these points, but I think there's great hope and optimism for the future, and people like you working in the field has really pushed the bar. So let's close out. Maybe I can go through a few of the SMART goals here, and then I'll ask you for some of your key take-home points. But the SMART goals, the specific, measurable, attainable, relevant, timely. So I think we need to engage, listen, and ask situational questions. Create a shared set of goals with our patients, especially as we think about disparities and some of these unconscious biases. In terms of treatment, we need to keep in mind gender differences in our IBD presentation and treatment, and especially pay attention to those at high risk for COVID and some of the distrust that has generally, as Sandra already alluded to, has been historically involved in a lot of our care. And we need to retain in care, ensure that patients keep their scheduled appointments, keep their follow-ups, approve and look at their adherence, and really stay on their medicines. I think you said, Sandra, to stay in remission is so important. So maybe, Sandra, before I wrap it up, what are some kind of key highlights or take-homes that you would like for our audience?
Sure. I mean, I think that I think these SMART goals are fantastic, and maybe like a concrete way to carry out that first one, the listening and asking situational questions. You could even maybe incorporate some of these questions into a patient intake form in terms of, what is your employment status at this time, or what income level, and you could explain what the purpose of that. But again, we have opportunities to monitor that, but if we don't ask the questions, we're not going to know. So asking these questions, and then also as we sort of set these goals with our patients, to then ask ourselves, what am I doing to support my patient so that they will be successful in achieving this goal? Or how are we together going to make sure that this happens? How can I make sure that they're able to keep their follow-up appointment, asking them about transportation access, asking them about, maybe their work schedule is a 9 a.m. appointment just not feasible for them, et cetera. So just asking those questions and then validating their responses. If our patient has a sense that they're not trusting the medical system, or if they're concerned about whether or not we're truly believing their symptoms, to validate them and to recognize that their concerns are absolutely reasonable, and that we're here to listen, to learn together, and to together with our patients, hopefully give them the best care and outcomes they can have.
Great. Well, Sandra, thank you again. This has been wonderful. And just a reminder to everybody, to receive your CME and CE credit, click on the link identified here to complete the post-test and evaluation online. We thank you again for joining us today for episode 2 of our 3-part CME Outfitters CMEOCast series. To view additional episodes on the management of underserved populations with IBD, please visit CMEOutfitters.com. Thanks again for participating. Thanks again for providing the best care for your patients. Stay safe and well, and have a happy new year.